Okay, AKI is treatable. So there are two forms of kidney damage. AKI used to be called acute renal failure. They've dumped that term because AKI is the more accurate description. Now, remember I mentioned this in dehydration last week? Okay, so there are many causes that lead to AKI. So the description again is rapid loss of renal function. There are three categories by which you can sustain AKI. Please read the COVID-19 consideration. This is because what happened in 2020 was you get COVID, right? And then you become septic because you catch pneumonia from COVID. So COVID leads to pneumonia, and then pneumonia leads to sepsis, and then sepsis means the blood pressure drops, and then that means it can lead to pre-renal AKI. Okay, so that's how COVID got in here. So COVID was one of the causes, but let's go to the classifications. Okay. So AKI can occur in one of three mechanisms. The patient may have one or more classifications, in fact. So it can be pre-renal, it can be intrarenal, or post-renal. Did I discuss this already last week?
No.
How come it seems familiar? Anyway, so we have table 48-2. So this is a rifle classification. Stands for that acronym, rifle, risk, injury, failure, loss, and ESKD. You'll notice that in all three, the basis is the GFR and the urinary output. Now, let me explain the difference between the two. GFR is glomerular filtration rate. Then urinary output, of course, what's our basis again? We can still do 30 ml per hour, but what's the more accurate? It's 0.5 mLs per kilogram per hour, correct? That's more accurate because, of course, a bigger person we would expect higher urine output, correct? All right. So when we say GFR, we can't use this in a hospitalized patient because when the patient comes in with AKI, the GFR will reflect a GFR of a patient who is in AKI. Does that make sense? Meaning, is it an accurate? No, because it's a GFR of an injured kidney already. Urinary output, however, is whatever that kidney is able to produce. Meaning, in an acute patient, meaning a hospitalized patient, we can't use a GFR. We have to base it on the hourly urinary output. You follow?
Yes.
Whereas if, let's say this is an outpatient scenario, let's say you're seeing the patient in a clinic, we will look at the GFR because that's a more accurate measure. Do you understand the difference between the two? Okay, because the urinary output will always be whatever the patient's urinary output is. So the GFR becomes less reliable in an acutely ill patient. Do you follow? All right. Now let's go now to the, I'm still looking for the, okay, there's no table for the classic. There is. Okay, sorry. Okay, chart 48-4. I found it. And then I'll go back to the phases. So let's look at the causes first. So AKI can occur in one or more of these ways. So we call them pre-renal if the AKI results from any volume depletion, meaning whatever condition leads to decreased blood flow to the kidneys, that's pre-renal. Examples are the following. So we mentioned about dehydration last week, right? So you can lose blood or fluid volume in a number of ways, correct? You're bleeding, or you have nausea, vomiting, diarrhea, or you're simply not taking enough fluid, so you're dehydrated. So any of these conditions lead to pre-renal AKI. Look at the other list that's included. That from diuretics, remember we just concluded heart failure, right? So does heart failure result in decreased blood flow to the kidneys? Yes, especially which type? Left side, right? So left side heart failure results in decreased cardiac output. So therefore, there's decreased renal perfusion. Arrhythmias. Okay, you have a there's no arrhythmia that will cause increased cardiac output. All arrhythmias lead to decreased cardiac output. Shock, heart failure, as already mentioned, heart attack. So we have many causes here. So any again condition that results in decreased blood flow to the kidneys, whether it's caused by fluid loss or simply decreased blood pressure. Any question on pre-renal? Okay, so let's go now to intrarenal. Intrarenal causes are any damage to the kidney organ itself, to the kidney parenchyma, to the kidney tissue. So these are some of the causes. Transfusion reaction, hemolytic anemia, which can result from hemoglobinuria, meaning there's blood in your urine. Is blood supposed to be in your urine?
No.
No, those are huge molecules, right? They shouldn't be in the urine, but then a condition occurred which causes injury, and now the kidneys is supposed to be only allowing small molecules to come out because it's injured. It's now releasing even huge molecules, okay, into the urine. Rhabdo, you know what is rhabdo? Okay, right. So this is destruction of muscle, right? Caused by trauma, crush injuries, or burns. Medications. So you have nephrotoxic agents from these antibiotics here, from contrast agents, for instance, iodine, IV iodine. Then we have NSAIDs, or heavy metals. Okay, so chemicals, or these infectious processes, acute glomerulonephritis. You'll talk about this in peds. And acute pyelonephritis, we'll talk about that later on module 9. And then we have post-renal, AKI. Post-renal is any cause that leads to obstruction of urine flow, meaning there's no problem with circulation. There's no problem with urine production. The kidneys are making urine. The urine is just obstructed. The urine cannot come out. As a result, kidneys return to, urine returns to the kidneys, causing hydronephrosis. So it can be caused by any of the following. So any obstruction of urine flow results in urine going back into the kidneys. That can cause AKI. Any questions on the causes? So, yes. So therefore, can this be, is it easy or hard to sustain AKI? No, to experience AKI. Very easy. Look at this, all numbers. Look at this long list of conditions, right? This could be in any patient. So therefore, is there a risk for every patient admitted to the hospital to go into AKI? Yes. If they didn't come in with AKI, could they experience AKI?
Yeah.
Yes. Let's go back to the phases now. There are 3 phases in AKI. It's important to know the phase so that we can know when to institute the interventions. Okay. I know this has 4 phases, but let's disregard the first one, which is initiation, because initiation pretty much is not really clinically significant. So let's start with the oliguric phase, okay, which is the next bullet. Oliguric phase, and then the diuretic phase, and then the recovery phase. Recovery phase is so long, so we won't discuss that today. We will only focus on the oliguric and the diuretic phase because these are the 2 most crucial. If you miss the transition, meaning if you don't monitor your patient and then the patient enters the diuretic phase without you knowing it, because let me explain. When the patient enters the oliguric phase, so remember there are 3 groups of causes, right? We have pre-renal, intra, and post-renal causes. So when the patient sustains any of those causes, they go into AKI. The first phase is oliguric, right? Again, let's disregard the initiation phase. It's not really clinically significant. So when oliguria develops, that means what is oliguria again?
Urine less than 400 ml.
Right. So why did the kidneys go into oliguria? What are they trying to do? Are they working? No. Remember the definition of AKI is sudden cessation of urinary function. So this is the initial reaction by the kidneys in response to injury. They stop or decrease urinary output. When they do that, when they become oliguric, how much urine were we supposed to make a day? Per day is what? 1500 ml per day, correct? That's the average urine output. So what happens now? They're only making less than 400. So what happened to the 1100? It's somewhere in the body. We know it's not coming out, correct? So now, what did we say about BU and creatinine? How do we get rid of BU and creatinine? Through the urine. So if you're making less urine, less than 400 ml per day, are you getting rid of BU and creatinine? So what happens to, okay, so now you have increased waste products in the blood. What happens to potassium levels? Also increases, and all those problems. So these are now the consequences. The patient has increased BU and creatinine, uric acid, phosphorus, potassium, magnesium. And then what is the patient's fluid status? They're in fluid overload. So therefore, knowing that, what will be our intervention? So we discussed interventions for fluid overload last week, which are, what do we do again? Restrict fluids. What else? Diuretics, etc. Now, the interventions here, though, will depend on the cost. So let's say, so it's not always going to be fluid restriction, because what if the cause is dehydration? If it's pre-renal, what will be the interventions? Do we restrict fluid?
No.
It will be the opposite. Okay, so meaning you still have to treat based on the cause of the AKI. So if the cause is hemorrhage, will we do fluid restriction? Of course not. We have to give fluids, etc. Okay, so we treat based on the cause. However, if it's the other causes, like here, intrarenal or post-renal causes, do we give fluids? No. You see what I mean? So it really depends on what is the cause. Is it pre-renal? Is it intrarenal? Or is it post-renal? Okay, let's go back to the phase now. But generally speaking, when the patient is oliguric, what is the general rule? So if the patient is in fluid overload, what are the interventions mostly?
SBS.
Fluid restriction in generally speaking, correct? Except again, if it's pre-renal. Now, you're correct. We still treat the manifestations. So the patient has hyperkalemia, we have to treat that. The patient has fluid overload, fluid restriction, you give diuretics, except again, if it's pre-renal. Okay. When the patient enters the diuretic phase, and you were doing those interventions, now the switch between oliguric and diuretic phase, we only know that it's a range of period. So granting the patient made it to the hospital and they're in the oliguric phase, right? The oliguric phase with treatment lasts anywhere between 24 to 36 hours. That's the period of the oliguric phase. Now, if you were, let's say, doing fluid restriction, correcting the potassium, giving diuretics, and then the patient enters the diuretic phase, which is now marked by increased urine output. The patient is making now over 1500 ml per day. So therefore, if you were doing fluid restriction and then they went into diuretic phase without you monitoring the patient, what could happen to the patient? They'll experience a second insult, okay, a second injury. they're supposed to go from oliguric to diuretic and then to recovery. If you miss that period, let's say you missed the signs, hey, it's Black Friday, you were on your phone, okay, watching for the sale, okay, bidding on something. Then here's your patient entering the diuretic phase and you did not know it. You continued giving after, you're pushing diuretic, no fluids for you, okay? And then just going about giving, the SPS, whatever was ordered. And then without knowing, the patient already entered the diuretic phase. So what's supposed to be done when they enter the diuretic phase? You're supposed to reverse everything, right? So opposite of what you were doing in the oliguric phase. So when you miss that period, then the patient will suffer a second insult. So instead of going into the recovery, the patient in the diuretic phase, which did not receive proper treatment, will return to the oliguric phase. When that happens, they won't snap out of the oliguric phase anymore. They'll stay there forever.
Wow.
This is now what we call chronic kidney disease. Okay, so AKI, these patients have a chance to recover if treated appropriately. If you miss the symptoms though, because if you miss it from the oliguric to the diuretic phase and you did not change the therapy, because doctors won't be there 24/7. Yes, they are, but they have other patients. So the doctors are relying on you to report to them when the patient has entered the diuretic phase. Because again, it's a range, right? We don't know exactly between 24 to 36 hours. It also varies depending on the severity of the patient's AKI cause. So let's say this patient went into shock and they sustain AKI. There's no way they're gonna recover in 36 hours, right? So depending, how soon did they recover from the oliguric to the diuretic phase? But it requires nursing assessment. Okay, close nursing monitoring that you're there watching the patient. Oh, then you reported, doctor, the urine output increased. Right? So yesterday it was only 360 for the whole day. Now this is only my shift. I'm already up to 1800 output. So is that normal? No, the patient made urine output good for the entire day in 12 hours. So that's diuresis. Eh? So you report that, doctor will say, oh, thank you very much. Let's change the therapy now. Are you clear?
Yes.
Okay. Is this a good select all apply question also? Yeah, and I can also put again, drag and drop categories, okay? So identify, okay, where these causes belong into pre-renal, intrarenal, and post-renal causes. Okay? And you play around, you drag the causes. Okay? Yeah, you take an exam, you might as well have fun. Yeah, see, yeah. Okay. Manifestations, so let's keep it simple. If the patient is in the oliguric phase, what manifestations do you expect? Dehydration or fluid overload? The oliguric phase.
The overload, sorry.
They're in overload. Okay. What about the diuretic phase?
Deficit.
Deficit. As simple as that. So look at table 848-3. So these are now your manifestations. Okay. They have similar for beyond creatinine, of course, because all will be elevated because your urine output drops. Here, look at between pre and intra. So the only difference here really is in pre-renal. Because in pre-renal, this is due to dehydration pretty much, right? Because it's fluid or blood loss. So that's the only thing that is different, the pre-renal causes. But for intra and post-renal, the manifestations are consistent with dehydration and fluid overload, respectively, between oliguric and diuretic phases. So our main basis would be the BU and creatinine, okay, and the urine output. So those will be your most reliable indicators of AKI. So every day you monitor the BU and creatinine, and then you monitor the hourly urine output. Now, what's the only way to monitor hourly urine output? What instrument do you need? A catheter. We have to put in the Foley. I know we don't want to put in Foleys, right? Because they're a source of infection, but in this case, this is a critical patient, so we have a justification for the Foley. Again, for GFR, yes, we look at it, but is it a really more reliable indicator or the urine output? The hourly urine output would be more reliable in this instance. Prevention, of course. How do we prevent AKI? What are the causes again? Pre, intra, and post-renal. So who will you monitor for AKI? Those patients listed under the three groups of causes. So patients with those diagnoses, okay? So those who come in with sepsis, which could include COVID, those who are bleeding, those who are NPO, those who are receiving antibiotics, right, NSAIDs, or those who are undergoing tests involving IV contrast agents, okay? And then those with enlarged prostate, tumors of the bladder or colon, for instance, or with those with kidney stones, okay? Right. So those are your high-risk patients, so therefore those are you monitor to prevent AKI. So that's summarized in chart 48-5. So monitor urine output in all of those patients listed with those diagnoses. Then once you identify AKI, prompt notification of the physician. How NSAIDs damage kidneys is through the mechanism of action of NSAIDs. How do NSAIDs relieve pain? How do they relieve pain? What is the mechanism of action? NSAIDs. You're warming, so continue. So what does it do? What is that neurotransmitter? Or simply put, it's prostaglandin, correct?
Yeah.
Okay. So prostaglandin is not only a neurotransmitter for pain, it's also a vasodilator. So if you take NSAIDs, which inhibits prostaglandin synthesis, yes, there will be less pain. However, there will also be less vasodilation. Now, look at the size. Imagine the size of your nephrons. Are they visible? They're microscopic, correct? So if they're microscopic, each nephron is wrapped by blood vessels, correct? Capillaries. So imagine the size of those capillaries. They're even smaller than the nephron itself, right? So therefore, if you take NSAIDs for a long time, several doses a day, so what happens to blood flow to those nephrons? So what will happen to your nephrons? They die off little by little. Okay, so that's what leads to kidney damage. Yes, you can take NSAIDs, but not too much, okay? Or if you have to, let's say patients who are taking, who have arthritis, they have to take NSAIDs, right? There's no other drug that will help with arthritis pain. So you give them, we'll get to that when we get to rheumatoid arthritis. That's for exam 2. Again, for medical management, this will depend on what caused the AKI. So it'll be specific to the patient's cost. Okay, so and whether it's pre-renal, intrarenal, or post-renal costs. Okay, that's how you treat AKI. So here, depending on what phase is the patient on, are they in the fluid overload, which is oliguric, or are they in the diuretic phase? I don't have to repeat it, right? I mean, if you're in fluid overload, what do you do? Okay, and you give diuretics, right? If you're in fluid deficit, you give fluids. Okay, very good, children. In some cases, the patient may undergo short-term hemodialysis. So this will be the fastest way to remove fluids and then also remove electrolytes, okay, to save the patient's kidneys. Because if we just leave them alone, and just let time take its course, the patient will lose the kidneys. So if needed, let's say that the creatinine is so high, okay, creatinine is 12, 15, normal is less than 1.2 is normal. 15, that's really sky high. So to save the patient's kidneys, we'll have to do short-term dialysis. Drug therapy, again, it depends on what is the patient's, what's the cause of the AKI. And then we treat them symptomatically also. Let's say Mr. Samuel mentioned about hyperkalemia. So what were our choices again last week for treating hyperkalemia? Regular insulin with dextrose. Yeah. Calcium gluconate, sodium bicarbonate, right? Okay, so all of those. So they repeat it here. And because what's the priority again when we're dealing with high or low potassium? Cardiac monitoring. Very good. Okay. Nutritional therapy, the patient will have to have controlled or restricted amounts of everything. Because where did BU and creatinine come from again? Protein. So what do you think will be the protein content of this patient's diet? It's going to be restricted. Okay, so less than normal. So let's say 70 grams, for instance, a day, or 60, depending on the patient's BU and creatinine level. Then what will we do with the potassium, sodium, calcium, magnesium content? Do we control them also? Yes, because the kidneys are not functioning here. So you have to control all of the amounts. And what do we do with fluid? Do we give normal amounts of fluid? We restrict the fluids because, again, no kidney function. Can the kidneys perform all of its normal functions, which is fluid and electrolyte balance? No. And elimination of waste products? No. So depending again on the patient's cause, the shortest time for the oliguric phase is between 24 to 36 hours. But depending on the cause, if it's, let's say, shock, it can be prolonged. I won't repeat these. These are the same ones we already discussed last week under fluid and electrolyte problems. I can't emphasize this enough, right? I believe we emphasized on this one last week. Okay, hyperkalemia is just as dangerous as hypokalemia. And what do we monitor again before giving any potassium supplement? What is kidney function? What do you monitor exactly? The creatinine and what's the most accurate? This is a sick patient. Hourly urine output is 0.5 mLs per kilogram per hour. BNP is for the heart failure. Okay. Everything's jumbled around now.
No, I said B.
Oh, okay. Sorry. Okay, for weights, don't cry. The nephrologists, when they mean strict INO, they mean strict INO. Urine output must be recorded accurately because the basis for fluid restriction is the patient's last 24-hour urine output plus insensible fluid loss. Remember insensible fluid loss? Okay, so fluid loss from talking, from sweating, from metabolism. Okay. So therefore, if you don't record the urine output completely, are we treating the patient properly? No. So don't be surprised if you'll be chewed out by the nephrologist. No, they wrote down strict INO and you didn't do that. So they'll have you written up. They'll tell your manager, they'll tell whoever they can tell. Okay? If they know your grandma's phone number, they call your grandma, okay, and tell on you. You know what your grandson or your granddaughter did? Did not record urine output. This patient needed that urine output recorded accordingly. You know what happened to the patient as a result? Then your grandma was, oh, let me talk to, okay, let me talk to, do you know what I mean? Gilla? Yeah. Let me talk to Jamie. Jamie, come over here. Yes, Mr. Lewis?
Um, I- for BNP of the
I know she was talking about basic metabolic panel, which is BMP. No, Bravo, Mama, Papa. Because others were saying BNP, which is for heart failure. Yeah. Yeah. And then daily weight also. Nowadays, can this patient get up out of bed and stand on a scale? So we have to have a bed scale, right? So make sure though that the bed scale is zeroed before you put that patient on that bed. Okay, because otherwise you won't have an accurate weighing. Then consider also what are other things on the bed. You put a bunch of comforters in there, blankets, pillows, patient's bag and purse is on there. Now you don't have an accurate weight. This one is about, can this patient go into heart failure? Yes, so kidney failure can go into heart failure as well. Preventing infection, remember early urine output, these patients will have a catheter, right, to measure early urine output. So make sure we do have interventions to prevent UTIs in patients with catheters, which include what? Where should you put the bag? Below the bladder. What do you do with the coochie? You wash it, right? Wash it with soap and water. And do you do also the chlorhexidine wipes?
Yes.
Okay, so you keep it clean when they're incontinent, because these are again sick people. They won't be able to get out of bed, so they'll just do number 2 right there in bed. Okay, and now there's it's all soiled with feces. Okay, so that means you have to really wash the catheter insertion site. Okay, very important. Can you delegate it? Should you delegate it? Oh, you should make sure you do it yourself because you want it to be done correctly. Okay. Yeah. I help them, meaning I don't leave it. If it's a patient with a catheter, I make sure I'm at least there doing the cleaning, because I can't. I just can't trust the because it's UTI, because the patient can die from that UTI. Okay? They can go septic and then they can die, which could have been.
Basically, you're there to monitor the quality control.
Yeah, exactly. I want to make sure. I mean, it's if you don't want to get in there, that's fine. But I prefer I do it myself.
Right.
Yeah. I'm an expert in cleaning doo-doo. Skincare. So patients, we'll talk about this later again when we get to CKD next week. We won't have time today. Because when the patient's kidneys can't get rid of BU and creatinine, the skin, yeah, they'll get some waste products coming out of the skin, causing it to be itchy, dry, and then of course, if it's itchy, what do? You scratch it, okay? All right, so we'll stop here. We'll do CKD next week. Okay, which is this part. All right, and then we'll talk about dialysis, etc. Quiz next week will be heart